Somewhere in a medicine cabinet or a kitchen drawer right now, there might be a small vial and a syringe sitting next to a bottle of pills, both promising to fix the exact same problem. Millions of people reach for one or the other every single month, and almost nobody stops to ask which one is actually worth it. That problem is vitamin B12 deficiency, and it is far more common than most people realize. It quietly affects older adults, people on long-term diabetes medication, anyone who has had weight loss surgery, and a lot of people eating a mostly plant-based diet. Vitamin B12 is not just another vitamin on a label. It is required to build DNA, to manufacture red blood cells, and to keep the coating around your nerves intact. Run low for long enough, and the effects show up almost everywhere in the body at once. Run low, and you can end up with a type of anemia that leaves you exhausted for no obvious reason, tingling or numbness in your hands and feet, memory problems that can look a lot like early dementia, and even a sore, inflamed tongue. Have you ever felt bone tired despite sleeping enough, and just assumed it was stress or age? For a surprising number of people, that fatigue traces back to a blood test result nobody ever ordered. A century ago, that same deficiency was not just uncomfortable, it was a death sentence. Doctors called it pernicious anemia, precisely because nothing they tried could stop it, and patients slowly wasted away. Then in 1926, two researchers named George Minot and William Murphy tried something almost absurd. They had their patients eat enormous amounts of raw or lightly cooked liver every single day, and against all expectations, it worked. Patients who had been dying recovered. Nobody understood why liver of all things could reverse a fatal blood disease, but the results were undeniable, and Minot and Murphy won the Nobel Prize in 1934 for a cure they could not yet explain. It took more than 2 decades to find the actual molecule hiding inside all that liver. In 1948, scientists finally isolated a deep red crystalline compound and named it vitamin B12, the ingredient that had been saving lives without anyone knowing its name. Working out its exact 3-dimensional structure took even longer and required a technique called X-ray crystallography, so demanding that solving it eventually earned Dorothy Hodgkin a Nobel Prize of her own in 1964. But there was still a missing piece. Back in 1929, a physiologist named William Castle had noticed something strange. Some patients could eat all the liver they wanted and still stay sick, because their stomachs were missing a specific substance he called intrinsic factor. Without intrinsic factor, the body simply cannot pull vitamin B12 out of food, no matter how much of it you eat. That single discovery explains almost everything about why this particular vitamin is so much trickier to absorb than any other. Getting vitamin B12 from your plate into your bloodstream is genuinely one of the most complicated journeys any nutrient makes. Stomach acid and enzymes have to pry it loose from protein in your food, then a carrier protein in saliva and gastric juice grabs onto it. Further down in the small intestine, pancreatic enzyme strip, that first carrier away so intrinsic factor from the stomach, can finally latch on. Only then, once it reaches a specific stretch of gut called the terminal ileum, does a dedicated receptor let the whole package through. Break that chain at almost any link: low stomach acid, missing intrinsic factor, a damaged or shortened intestine, and vitamin B12 absorption can collapse even if your diet looks perfectly healthy on paper. So why has an injection become the almost automatic answer to a deficiency you could, in theory, just swallow away? For decades, the logic seemed airtight. If the problem is a broken absorption pathway somewhere between your stomach and your gut, then swallowing more of the vitamin should not help much. Better to skip the gut completely and put it straight into the muscle. That is exactly what an intramuscular injection does. A needle delivers a concentrated dose of vitamin B12 directly into muscle tissue, where it slowly leaks into the bloodstream over days, completely bypassing digestion. Medical guidelines still lean hard on this approach for patients with confirmed malabsorption or a severe, symptomatic deficiency, and for good reason, since those are exactly the people whose gut cannot be trusted to do the job. But an oral pill is not quite as helpless as it sounds either. Even without any intrinsic factor at all, a small slice of any oral dose, somewhere around 1 to 2%, can slip through the intestinal wall by simple passive diffusion, no special transport required. Take a small percentage of nothing and you get nothing, but take a small percentage of a very large oral dose, and it turns out you can still push meaningful amounts of vitamin B12 into the blood, even in people whose absorption machinery is broken. That loophole is exactly why some clinics started experimenting with high-dose oral tablets as an alternative to needles, even for patients who technically could not absorb the vitamin the normal way. Somewhere between the needle and the pill, a third option has been quietly gaining ground. A tablet or spray dissolved directly under the tongue, absorbed straight through the lining of the mouth instead of passing through the stomach at all. The idea behind sublingual dosing sounds almost too convenient, all the benefits of an injection with none of the needle. But for years, nobody had pooled every trial together to find out whether that convenience actually held up. And this is not a small, niche decision either. Vitamin B12 deficiency is common enough, especially as populations age worldwide, that the choice between a pill, a spray, and a needle plays out in doctors' offices every single day, millions of times over. Every one of those choices carries real weight. Injections mean recurring clinic visits, a nurse's time, and out-of-pocket costs that adds up year after year for a condition many people will carry for life. Chronically low vitamin B12 also raises homocysteine, an amino acid that at high levels has been linked to blood vessel damage and cardiovascular risk, which is one more reason getting the treatment right matters well beyond how tired someone feels. If a cheap bottle of pills or a $2 sublingual spray worked just as well as a monthly trip to the clinic for a shot, that would matter enormously, not just for one patient, but for how medicine treats an extremely common condition everywhere. So a team of researchers set out to finally settle it by pulling together every comparative trial on vitamin B12 delivery that had ever been published and analyzing them side by side in a single unified model. The tool they used is called a network meta-analysis, a method that lets scientists compare treatments even when not every study tested all three head-to-head, by linking the results through whichever treatments the trials do share in common. Does the needle actually beat the pill? After combining 13 separate studies and 4,275 patients with a confirmed vitamin B12 deficiency, all treated with either oral pills, sublingual tablets, or intramuscular injections, the researchers finally had an answer. The first finding was almost reassuring. Regardless of which of the three routes a patient used, their vitamin B12 levels in the blood went up. None of the three options failed outright. When the researchers ranked the three routes against each other for raising raw B12 levels, injections came out in first place, sublingual dosing came in second, and oral pills trailed in third. But that ranking came with a major asterisk. The gap between the routes never reached statistical significance, because there simply were not enough trials to say for certain that the differences were not just noise. The picture flipped almost completely once the researchers looked past raw B12 numbers and checked hemoglobin instead, the marker doctors actually care about, because it shows whether the underlying anemia is resolving. On hemoglobin, oral pills ranked first, ahead of injections, which came in second. Once again, the difference between routes was not statistically significant, but the needle had lost its edge entirely on the outcome that matters most. Across every other blood marker the team checked: red blood cell size, platelet counts, white blood cell counts, and homocysteine. There was no meaningful difference between oral pills, sublingual tablets, and injections at all. One deeper statistical model did flag a significant difference between oral and intramuscular dosing, specifically for raising B12 levels. But the authors were upfront that this difference never showed up in hemoglobin or any other marker of real recovery, so it carried no proven clinical benefit. Sublingual dosing quietly came out looking like the real winner of the whole comparison. It matched both oral pills and injections across essentially every outcome measured, while skipping the pain and clinic visits of a needle and sidestepping any doubt about gut absorption that can complicate a pill. Cost adds one more layer most people never think about. Intramuscular vitamin B12 is consistently more expensive than oral or sublingual formulations, on top of requiring a clinic visit or someone comfortable giving the injection. None of this means injections should disappear from clinics. Current guidelines still favor the intramuscular route for patients with confirmed malabsorption or severe, symptomatic deficiency, and this analysis was never positioned to overturn that for the sickest patients. What it does challenge is the reflex to default to a needle for absolutely everyone else, when a cheaper pill or a needle-free spray under the tongue could realistically be doing just as much good. The researchers frame it as a decision that should be made person by person, weighing how severe the deficiency is, whether the gut is actually absorbing nutrients normally, how well the patient tolerates each option, and increasingly, what it costs. The study, Efficacy of different routes of vitamin B12 supplementation for the treatment of patients with vitamin B12 deficiency, a systematic review and network meta-analysis, was led by Omar Ahmed Abdelwahab and colleagues, and published in the Irish Journal of Medical Science in 2024.